Welcome. My name is Amy Knowles, and I am the Assistant Dean for Student Affairs and Admissions here at New York University College of Nursing. It is my privilege to welcome you to today's lecture entitled, The Supreme Court's Healthcare Ruling, Implications and Opportunities from a Nursing Perspective, presented today by our faculty scholars, Dean Eileen Sullivan-Marx and Dr. Christine Kovner. Our first scholar, Dr. Eileen Sullivan-Marx, joined NYU in July as the Dean of the College of Nursing and Erline Perkins McGriff Professor of Nursing. A distinguished nursing leader, educator, and clinician, Dean Sullivan-Marx is nationally recognized for conducting innovative research, developing new approaches in caring for older adults, sustaining models of care using advanced practice nurses locally and globally, and creating health policy in community-based, long-term care settings. She recently served as an American Political Science Congressional Fellow and Senior Advisor to the Center for Medicare and Medicaid Services. Prior to her deanship, Dr. Sullivan-Marx was at the University of Pennsylvania School of Nursing, where she held the titles of Professor of Scholarly Practice, Associate Dean for Practice and Community Affairs, and the Shearer Endowed Term Chair for Healthy Community Practices. While at the University of Pennsylvania, she led and integrated the School of Nursing's award-winning practice and community mission. Dean Sullivan-Marx's exemplary clinical career began in 1972. She earned a baccalaureate degree in nursing in 1976 from the University of Pennsylvania and a master's degree in nursing in 1980 from the University of Rochester School of Nursing. After years of professional success as a primary care geriatric nurse practitioner, she went on to complete her PhD in nursing in 1995 from the University of Pennsylvania School of Nursing. Our next scholar, Dr. Christine Kovner, is a professor at the College of Nursing at New York University, a senior fellow at the Hartford Institute for Geriatric Nursing at NYU, a nurse attending at the NYU Langone Medical Center, and serves on the executive committee of NYU's Clinical Translational Science Institute. Dr. Kovner maintains an active research program on RN workforce issues, including studies on quality improvement and working conditions and the cost of nursing care. Dr. Kovner is the principal investigator of a grant from the Robert Wood Johnson Foundation aimed at studying the career trajectories of newly licensed registered nurses over the first 10 years of their careers. She is the co-author of Financial Management for Nurse Managers and Executives, has published numerous peer-reviewed articles, and has served as a grant reviewer for government agencies and prestigious foundations. She serves as the Senior Associate Editor of Policy, Politics, and Nursing Practice. In addition to these roles, Dr. Kovner is an advisor to government and the private sector. For 9 years, she was a member of the New York State Hospital Review and Planning Council, and she is on the steering committee for New York's Nursing Workforce Center. Dr. Kovner earned a baccalaureate degree in nursing in 1969 from Columbia University and a master's degree in public health nursing administration in 1972 from the University of Pennsylvania School of Nursing. We are very proud that Dr. Kovner earned a PhD in nursing research and theory development in 1985 from New York University, and a postdoctoral research fellowship from 1987 through 1990 at New York University in cost of care. She is one of the college's most consistently funded researchers. It is my pleasure now to invite Dr. Kovner to the podium. Dr. Kovner.
Good afternoon. Welcome to New York University. What we're hoping to do today, Eileen and I, is talk for about a half an hour between the two of us, and then allow at least a half an hour for interaction with the people in the room, questions, comments that people will have, but our goal is to have this be very interactive. I'd like to know a little bit about who's in the room. How many of you are alumni from our College of Nursing? Oh, so not so many. How many of you have some other relationship with nursing, that you're a nurse, a family member, nurse? No. Oh, some people. Okay. Well, you're a nurse. That's great. And how many people are involved in some other way in healthcare? And so there actually seem to be a lot of people in the room who are not directly associated with nursing. So that's useful to know in terms of some of the comments that I make. Do you remember ever seeing headlines like this in the, like 2008, 2007? Everybody was worried. There's a big nursing shortage. Who was going to take care of my mother when she got to the hospital? And more importantly, who was going to take care of me when I went to the hospital? Something happened in this country in 2008 that had some impact on that. We had what some call the Great Recession, and it was probably the worst economic crisis we had in this country since the Great Depression. At that time, and particularly when there was a shortage, people kept saying, is nursing a good career? That was one important question about nursing. And the second question was what I said before, will there be enough nurses to take care of us? In 2008, there were great reports of a future crisis in nursing, that there would not be enough nurses to take care of us. Between the Great Recession and maybe the last year, what we saw nurses do was to come back to nursing. Many nurses who had not practiced in several years, a partner, another family member, lost his or her job, and they came back to nursing. And also, something that made a very dramatic impact on the number of nurses is many nurses who worked part-time increased their hours, such that they were working full-time, and there's so many nurses who work part-time that such a change has a dramatic impact on the number of nurses in this country. We got reports from across the country that young graduates were not able to find jobs. I'm proud and honored to say that that was never true of the NYU graduates. Our graduates consistently through the entire recession, or if we're still in the recession, were all able to get jobs. Sometimes those jobs weren't their first choice. We have graduates who would like to work in the pediatric emergency room, and there's not very many of those jobs to begin with, so they weren't able to do that. But all of our graduates got jobs. What we see happening, I run a major longitudinal study of new nurses that we're in our 6th, 7th year of data collection, is that associate degree nurses are having a substantially harder time getting jobs than baccalaureate graduates. So what does that mean for us going forward? I wanted to tell you just a few quick things about nurses that you might not know. We have a lot of nurses in this country. Nurses are the most popular health occupation. And from 1980, the green line are those employed in nursing, and the red line is the number of nurses. So in 2008, I'm really sorry that I don't have more recent national data. As an aside, your tax dollars have historically paid for a fabulous survey of nurses every 4 years. And so that would normally mean that the government would be currently doing that survey. In their wisdom, they have decided to stop doing that survey. And it's an expensive survey, but it's not that expensive a survey. So I'm still stuck with 2008 data, and I fear that 4 years from now, or next year if I give this talk, I'll still be talking about 2008 data. Anyway, there's lots of nurses. They work. And despite anything you may have heard to the contrary, over these years, there are more and more and more nurses. One of the, I think, interesting aspects of nurses is that they are aging. They're aging just at a time when the rest of us are aging and we need them to take care of us. This shows the top spot here shows the average or the mean, I guess where most nurses are, age of nurses. And you can see that back in 1980, most nurses were 25 to 29 years old. And what has happened over time is that the nursing population has aged dramatically. Related to that is the age of nurse faculty. The average age of nurse faculty in New York State is about 58. And although people are delaying retirement, we have some concern that going forward, not only may we not have enough nurses, but maybe not enough faculty. This is a slide that shows over time, 2000, 2004, and 2008, the percentage of nurses who are white. And you can see that that percentage is about 83%. That is not at all consistent with the population of whites in the United States. And we have a lot of concerns in nursing that we do not have enough nursing staff from ethnic and racial minorities. How did I do that? Oh. Okay. Highest degree. This chart will show you that historically, here, about 55% of nurses in the United States were educated in diploma programs. That has gone down dramatically over time, such that now it's about 14%. At the same time, more and more nurses became educated at the associate degree level. Here are the bachelor's or higher level. So currently in the United States, about 50% of nurses have a bachelor's or higher degree. The Institute of Medicine, a very prestigious quasi-government agency, had a commission on nursing that issued a report on what should happen with nursing in this country. And their recommendation was that the United States have 80% of their nurses have a baccalaureate degree by 2020. So we have much to do to get to there. What's the work life like? I think I mentioned before how many nurses work part-time. Of the nurses who are working, about 63% work full-time, 21% work part-time, and the remainder do not work in nursing. 62% of nurses work in hospitals. There's been lots of talk since when I graduated from college, which my friend Amy told you was 1969, so now you know how old I am. But I was very young when I graduated from my nursing program. There was talk that more and more nurses would be working in the community. That has happened somewhat, but not nearly as much as we expected, and 62% of nurses still work in hospitals. Many nurses go on to become nurse practitioners, and NYU's College of Nursing has a large nurse practitioner program in many specialties. One of the things I find fascinating about the United States, particularly in light of the Supreme Court decision, is that we have 50 states and some territories. And every state and every territory has different rules and regulations about nurses and about physicians and about dentists. And that is one of the, I guess, wonderful characteristics about the United States, but there's many times that I wish that we didn't have 50 states. What that means is that what nurse practitioners are allowed to do in the various states varies quite dramatically. As you can see in this chart, the blue states are those states that have restrictive collaboration, restricted collaboration requirements. And that means that nurses must be in some kind of a relationship with a physician, and by in a relationship, I don't mean a romantic relationship, I mean some sort of contract or some practice arrangement. And you can see that New York, our favorite state, is still there. The light blue states, nurse practitioners have to have some kind of relationship with physicians in order to prescribe pharmaceuticals. And I don't know what color this is. I guess we could pretend it's purple because we're at NYU. Those states have no restrictions, except for Utah. You have to have a relationship with a physician in order to prescribe controlled substances. Now, what's interesting about this slide, if you think about the geography of the United States, is the states in which there are no restrictions tend to be states with large rural populations. Now, New York, of course, also has a large rural population, but we have been unable thus far to convince our legislators and governor that we should have regulations similar to what some would call the most advanced states, like Arizona and New Mexico. The Institute of Medicine report also recommended that these rules be changed in all the states so that one day we can have a purple NYU-looking map here. So what's going to happen long-term with the growth in jobs? When I use this slide with my students, I will say, how many people think there's going to be a shortage of nurses, and how big do you think that shortage is? We have guesses all over the place. The problem is nobody knows. There's an expectation that we'll need 3.45 million registered nurses by 2020. Remember, we have about 3.2 million now. But it doesn't mean that we'll just need an extra 250,000, because what's going to happen is many people are going to retire. So maybe we'll need another 450,000 nurses to be produced between now and 2020. We also don't know what people's retirement plans are. We see among our colleagues at NYU that people are working much longer and may not be retiring at the rates that they used to. So that's a little background about nursing in this country. The Supreme Court ruling, if you recall, had two major portions. One of the questions the court was trying to decide was the individual mandate. Could the government require people to obtain health insurance, or if they didn't in some way, they would have to pay some type of penalty? That was upheld. The other major part of the ruling was that Medicaid would be expanded dramatically by the states. Now, if you recall back to that map of the United States where the rules are different everywhere, the same is true with Medicaid. In fact, it was more than 20 years after the law was passed that Arizona finally got a Medicaid program. That was rejected by the court. And essentially the court said the government cannot make states, the federal government cannot make states expand their Medicaid programs. The government has included many incentives to make this happen, and so I'm hopeful personally that, in fact, most of the states will expand Medicaid. I'm quite confident that New York will. but we won't know for many years what will happen. So some key points of the Affordable Care Act, and Eileen is going to talk to you more about the details of this, is 50 more million people will get Medicare, which Medicare will get 50 million Medicare beneficiaries will finally have access to preventive services. Under the current regulations, if you go to a physician for a checkup and you have nothing wrong with you, that's not reimbursable, but it will be reimbursable. There will be no co-payments for many people. And we think what this is going to mean is a substantial demand for primary care providers. And I personally think that among the best could be this little cute boy. This little cute boy. He's 7. He's my grandson. He could become a nurse practitioner. So he could take care, a geriatric nurse practitioner. That would be my dream. Okay, so I'm going to talk a little bit about the Affordable Care Act. See how I'm doing time-wise. I actually am not. Eileen is going to go into the details of the Affordable Care Act and how we think that impacts people in this room, whether you're involved in healthcare or not involved in healthcare. You ready, Eileen?
Well, going into the details of the Affordable Care Act, I'll give you a warning. You can run for the hills if you like, because it could take us forever to talk about. So really what I want to do is highlight and where we're at and what does it mean from us as a nursing profession. And also, nurses every year when they do surveys of who are the professions that people trust more or trust the most. Nurses were always up there as one of the top, along with firemen, that are trustworthy. And often it's nurses who people come to and say, well, what is this really all about anyway? So that's why we thought we would try and give you our perspective of what this is all about anyway. And I've spent the last 2 years as a fellow through the American Political Science Association Congressional Fellowship as a Health and Aging Fellow with the Centers for Medicare and Medicaid Services in Baltimore, or on the phone on working on the rules and regulations and of what could be happening for the Affordable Care Act. So sometimes I can get so much into the weeds that you'll all be asleep on this lovely day. But rather than do that, we'll talk about this. So the Affordable Care Act covers some things for nursing workforce. So you saw the problem that we think we have this great demand for nursing and not enough nurses, and the faculty are retiring at rates and we need to prepare more. So that there is funds in the Affordable Care Act to test in 5 places use of the Medicare dollars, which usually fund either physician residency programs through the graduate medical education funds, or those hospital education programs called diploma programs that are reducing. So how can you take some of that money and help to increase the preparation of nurse practitioners in training programs and through hospital programs? And there's pilot money there, so that's a nurse workforce thing. And it's really focusing on the advanced practice nurse education for this primary care shortage. And also the identification that in community health centers, increasingly, since I was a doctoral student, we looked at a study of community health centers in which nurses were either using grant money or whatever to go into rural or city neighborhoods to provide primary and community health care. And that movement has really grown in the United States, where there are nurse-managed clinics. And in a for-profit world, you see that now, where you see nurses in pharmaceutical companies or in pharmaceutical stores like CVS, Walmart, where you can go in and see a nurse for a short-term problem. And it really grew out of this movement of having nurses. So there's the Affordable Care Act does provide for innovation testing and promotion and scaling up of those programs. Primary care prevention is a fundamental component of the Affordable Care Act. And what that means is that rather than not having insurances cover wellness or checkups or education around diabetes. We had a program here this morning in this room for our alumni sponsored lecture on diabetes and the soaring diabetes, and if you can get ahead of that through prevention and cover the education, how much improvement you have in outcomes of that. So that's provided for in the Affordable Care Act. But one of the keys is this area of care coordination, and I know that we all have experienced the lack of care coordination through the best efforts of ourselves, our families, our health professionals, our nurses, and our physicians. And there is, in the Affordable Care Act, provider and patient rights, and so that you have access to your information and access to services that is guaranteed in ways that it might not have been. And if you think about the 50 states issues, again, often when you go from state to state, you can't get the same coverage or the same access to services. And this is what we have currently in the health system, as we know, that we've got a lot of fragmentations of services. It's here, it's there. Can you transfer information? You know, I moved to New York City this July, so I had to get discs downloaded on things that I wanted to come up so providers here could see the same images of things in Pennsylvania. And, you know, I had to, well, we're not sure we really can release that. And I had to stand there and beg and plead. And, okay, we'll give you this. And then I come up here. Well, maybe, you know, maybe this just doesn't fit in the machine in New York. And, you know, we've all been through these sorts of things. We have an aging and sicker population, and I'll show you some information on that. We have a shortage of basic primary care services. If you think you've got a cold that's hanging on, not getting any better, you know, who do you go to for that? Or do you end up in the emergency room, which is the most costly way to get that handled? And we have problems with safety and medical errors because of this fragmentation and moving about, and we have high costs. And with all of that, how's the Affordable Care Act going to be adjusting that? Well, one of the things that you just heard about was this expanding of Medicaid. So for those who are most in need of care and who incur the most services and the costly services are older adults, meaning people over the age of 65 who qualify for their insurance through both Medicare and Medicaid. So that means people who are eligible for Medicaid because of income. So their income is in such, reaches such a level, $26,000, $20,000, $28,000, $18,000, whatever the state says it is for that year, then they are eligible to receive their health benefits through Medicaid. And if they're over 65, they also have Medicare. So they're what's called dually eligible. These individuals are the individuals who have multiple chronic illnesses and functional impairment at the same time. And because of those chronic illnesses and functional impairment, they are also people who have, therefore, increased visits to emergency departments, hospitalizations, and use in home care. So the coverage and the cost of that coverage goes up. So currently there are 9 million people in the United States who are dually eligible for care, and they represent 21% of the Medicare population and 15% of the Medicaid population. But they represent a disproportionate share of the spending in those, so that you see that dual eligibles who are on Medicare, they have more cost if they're Medicare alone than if total Medicare spending $299 billion compared to if they're not dually eligible. So it just represents in those graphs how much. So here's what we think of as the future of nursing and the past, building on our past. This is kind of a fun slide that I put together so you can tell that I'm a baby boomer, because if you don't know, that's the nurse from Star Trek. And who, you know, when I was 14 years old, you know, was, yes, I want to be like that nurse, maybe not the hairdo, but definitely the one who's holding this thing up and calling Dr. McCoy, but has everything, because he was always like, whoa, what are we going to do, Leonard McCoy? And then Florence Nightingale, who was the first epidemiology statistician in the world, who pulled together the diseases to show morbidity and mortality, and the nurses in the past who were public health nurses in New York City, who went into the homes to address both prevention, wellness, and then diseases. And then nurses who are out there seeing patients in all settings and where people live, work, play, and are sick. And then this is the RN in the center, and this very futuristic look was from several years ago. There was a textile display of nursing uniforms in Philadelphia, and this was the uniform that was designed to represent the future nurse, where you had all your paperwork, sort of like a cargo pant kind of a look to you, but the idea that you should be an RN. And then, as Chris mentioned, the future of nursing is that this initiative that came from the Robert Wood Johnson Foundation, funding it through the Institute of Medicine, which gives reports to Congress on different commissioned reports and what should be done. And that the individuals who looked at this were from Consumer. Donna Shalala co-chaired it. She's president of Miami, but was head of the Health and Human Services under President Clinton. Jack Rowe was on the commission as one of the chairs, and he has been on our board of advisories at the NYU School of Nursing. But they wanted to look at how to improve health care to be delivered by nurses, and had 4 key messages, but I just want to point out 2 for the purpose of the Affordable Care Act. And that is that nurses need to be able to practice to the full extent of their education and training and remove barriers to practice. So there's insurance barriers to how nurses should do things, but nurses can do a lot more than they're always utilized. So that's true for nurse practitioners. We may or may not be able, if you're in one state, to prescribe medicines that people need. Nurses, practitioners, and nurse midwives in Pennsylvania for a long time, the midwives who did a large part of the prenatal care for women who were pregnant couldn't prescribe vitamins, and now they can. So small things like that just simply get caught up in bureaucracy. But one of the things I like to talk about is that when you're in the hospital, nurses know how to order nutrition. They know how to order diets. They know how to do that, but we're not allowed unless a physician comes in that you got to wake up if they're sleepy, or wait for them to come in and you're starving, or you're concerned about your mother. Or what happened to me, my son was, had an athletic accident, bump on his head, had to be observed for a concussion overnight, and he was starving to death, but they said he couldn't have anything. But, his stomach's growling, he's jumping around the room. He certainly could have had something to eat, but you had to wait for this order. When we did that, looked at some studies of that in intensive care units, people were essentially starving in intensive care units. And, how do you heal if not to get a better food and better diet into you, but you had to wait this long bureaucratic effort. And so nurses should be able to order food for people. And then the other one to think about is that nurses should be full partners with physicians and others in redesigning healthcare, and that's increasingly happening. There are interprofessional education competencies now that all of the curriculum are being recommended by the American Association of Medical Colleges, the American Association of Dental Colleges, and Nursing Colleges to build into our curriculum for certification that we train people to work together across the professions, and that we all know how to inform how the healthcare should be better. So in the Affordable Care Act, these are the 3 things to keep in mind that what was driving how to improve care. And so part of the Affordable Care Act put a large part of the dollars that would come from savings, which you can debate. So some of the adjustments in dollars that would be moving forward came from the to fund what's called the Center for Medicare and Medicaid Innovations. And this is a new department at the Center for Medicare and Medicaid Services, is where all Medicare financing is. And this particular innovative center has $16 billion. And they are putting out every year asking for people to come forward with proposals to come up with things that address better health care, better health, and lower costs through improvement. And so we will see how to, it may be that you have a model that really works, but how do you scale it up? How do you take it across the country, et cetera? So from a nursing perspective, what does the Affordable Care Act mean for you? One, the individual mandate for coverage. By having an individual mandate for coverage, people will get the care they need earlier than before they have a problem that's more costly. So rather than get care in the emergency room because they put something off, they can get care, they can get it covered earlier. Coordinated care with bundled payment. This is the most important thing, and regardless of who gets elected, regardless of what the Affordable Care Act is going to happen, we're going to see this because the market's already putting this into place. coordinated care with one payment going in one place is what the insurance companies are already driving, so that you will find that particularly in my state that I then know the best, but also in upstate New York, where you have groups of 1 or 2 physicians, a couple of nurse practitioners working together, are going to network with larger groups so that people can benefit from a shared diabetic educator, from a shared physical therapist, from coordinating what makes things work better. Innovative models are going to come out of it. I already mentioned the graduate nurse education so that people can be onboarded better into their jobs from schools of nursing. And patient-centered care. There's a lot of studies that are now being funded for what's called the Patient-Centered Outcome Research Institute, which is also a part of the new initiatives in Washington, so that care, is at the patient level. And so that you will know more about what's happening for you, and that can take place. What does it also mean for you is that there'll be a single plan of care that's interdisciplinary, so that you will have your records available to you. You will know what's going on, and you'll be able to relate this information, and the information about your health will be at one point of care, and people will be able to go to that point of care to see what's going on and to pull it together. The promotion of wellness and primary care. So why shouldn't exercise be funded by your insurance companies? It saves time and money, and it prevents problems. Community health centers, how to scale those up. They're working, they provide primary care, they prevent hospitalizations. My center in Philadelphia was saving 85 cents on the dollar for every Medicaid dollar that was spent by reducing emergency room visits and hospitalizations. But how do you take those so that they're on every few street corners, and so that the Duane Reeds of New York City have a community health center in it that people can go to, where all the information is available. And better transitions. This is one of the fragmented things that occur. What happens when you have an illness from home, hospital, nursing home, back, in between? All of that right now is driven by payment. My father-in-law had a mild stroke in the spring. He was, with myself, my husband's a physician, I'm a geriatric nurse practitioner. Between the two of us, we still couldn't prevent him from being bumped around 7 different places in a couple of 3 weeks, or not 3 weeks, about 7 weeks. So it was, what was going on with this that we couldn't, and it was all insurance. And so I said, the way to stop this from happening is to change his insurance, and then get him on a different insurance type of program. And we called the insurance company and got him on something where he's in a total different situation, and he is on a palliative care system plan now, and we pay a small amount per month, or he pays a small amount per month, so that he can just be cared for in one place with a coordinated team. Those are the kind of things you're going to see more. And from a nurse, what will it take? And this is my last slide before we go to discussion. It's going to take a huge culture change, huge, so that the idea of really starting with wellness, primary care, and thinking about how you do that and that it's covered will really take a different change. Interprofessional education and interprofessional working together takes a huge change. The program that I had at Penn was for older adults who were dually eligible, who were eligible for nursing home level of care, which required an interdisciplinary team to put that together under a bundled payment system. And we had to retrain very experienced staff to think about how to deliver that care in a different way. But putting us, in the center of control is going to be another thing that will make this change. Data and technology are going to be huge, and it's going to take a good 5 to 10 years of working with data systems and technology before that really gets to work the way it will benefit us. We're getting started in that way, but it's going to take a while. Workers and professionals need to move away from individually feeling like they're the only person responsible for the care of their patients to what I call the esprit de corps, that we're all in this together and we got to work together. And that's not how we've been educating nurses. It's not how we've been educating physicians or dentists. We make everyone feel that they're the ones responsible for everything. But we've got to get people working differently. And then we've got to bring the care to where people live, work in their relevant neighborhood, instead of thinking you've got to go over here. But how do we bring it there? In rural areas, it may be through telehealth and telehealth care and telemedicine, so that you're Skyping and learning about that. And there's some fabulous work in that area going on around the country. So I'm going to stop there and ask Chris to come up, and we're going to go to these sit-down microphones. And I think some of our staff have microphones in the back, and for you to use if you have a question. And Amy is going to come back and be a moderator for us. So thank you. We're videotaping, by the way, so that if I guess we would need your okay verbally if you get to the microphone. But we had a lot of requests from alumni who couldn't be here to see if we could have that on our website or available to people. So we are videotaping the session.
Well, thank you, everyone. At this time, I will take questions. We do have 2 microphones in the room. Ms. Christine Biela and Mr. Brad Temple have microphones. So as I call upon you, either Christine or Brad will present you with a microphone and will ensure that your question is heard. So I shall take the first question. We have a question here, mid-row.
My question is about nurse practitioners, because we had an experience where we were in upstate New York and there weren't any doctors available, and we had a nurse practitioner, and she was absolutely fantastic, and she knew so much. And I started thinking that she didn't really know any less than a regular doctor who was a general practitioner, not somebody who's a specialist like a heart doctor, but just a regular GP. And so why do these GPs have to go and have all these extra years of internship, residency, etc., when the nurse practitioners are so good?
Thank you for your question.
Chris is pointing it to me. Thank you. Thank you. Excellent question. And if I could have a nickel for every time I've heard someone say, and I saw this nurse practitioner, I'm always ready to hear like, and they said, and it was absolutely fantastic. So thank you for that. For many years, nurse practitioners, as that term, really began in 1965 to fill the need for children's health care in Denver, Colorado, and around the country. And there was a tremendous shortage of primary care, and public health nurses and community nurses were educated, and then it evolved. So that when I was a nurse practitioner, educated at Rochester and ended in 1980, finished my degree, there were 12,000 nurse practitioners in the U.S., and now there's 150,000 to 170,000 nurse practitioners practicing. But they are available, and they are people who remain sometimes in communities near their homes, and sometimes conglomerate where the rest of the health professionals are. So we've always had that question, and one of the pushbacks that we used to get, well, nurse practitioners, it's 2 years. How could that possibly be enough time? When your question is when physicians, spend 4 years and then 3 years in training if they're internal medicine after the 4 years in medical school, et cetera. And I used to say to people, well, I think there's some over-preparation going on. And not that we're underprepared, but there's over-preparation. And over time, it's actually coming closer and closer together. So at NYU, and I don't want to, jump ahead, but the School of Medicine is preparing to have a 3-year medical school program. And our nurse practitioners are prepared in a doctorate of nurse practitioner program, and that's about 2.5 years. So actually, I think what your question is exactly what's starting to happen. And that's what these 5 pilot tests in the Affordable Care Act are looking at. What is the training that we're using Medicare funds for? Because Medicare funds all physician residencies through graduate medical education funds. So what's the best use of those Medicare funds, which is what the Affordable Care Act? And so I think you're going to see that coming together more and more.
Thank you, Dean Sullivan-Marx, and thank you for your question. A second question. A question in the back, the woman in the brown.
Yes, I've worked with nurse practitioners in the emergency room. And I know that in terms of reimbursement, a lot of the insurance companies won't reimburse if a nurse practitioner does a particular service at the same level as if an MD does the exact same service. So I was just wondering if under the Affordable Care Act, were you able to achieve parity?
Thank you for your question.
That would be my wish, but no. The Affordable Care Act, we tried to get that into the Affordable Care Act, that there would, through Medicare, be equal payment, because through Medicare, nurse practitioners receive 85% of the prevailing physician rate for the same service that's delivered, that's recorded under the current procedural code or the diagnostic criteria. That's not true for all insurance companies, because some insurance companies in a fee-for-service system will pay the same fee. And Medicaid, depending on the state, pays the same fee, or 75 to 100% depending on the state, because the states can control for that. So that did not change with the Affordable Care Act. What did change with the Affordable Care Act is, rather than have payment run through what you're describing as the fee-for-service model, it's a bundled payment model, so that the payment would go to a group of individuals, the employers in the emergency department, and whatever care is being delivered, it's bundled. I'm oversimplifying it right now, but that's the difference in the Affordable Care Act, is to create incentives away from fee-for-service and more toward paying for the level of care that's appropriate for the person. Pay the person for the level of care that's appropriate, that's being delivered. So I could talk to you afterwards about a lot of details in that area, but it did not change the fee-for-service payment.
Thank you. Question in the front, first row.
I'm assuming that if Barack Obama is reelected, that the Affordable Care Act will continue to develop as you've described it. If, on the other hand, Mitt Romney is elected, how will it change? He's spoken about turning it over to the 50 states. Is it possible to have 50 different programs? Will we lose coordination if it's not directed from the federal government? Can he really do it?
Thank you.
I guess he could do whatever he wants. But I think the important thing is that we have three branches of government, and it's not clear whether, if Romney became president, whether Congress, in fact, particularly the Senate, a lot depends on what happens in the Senate, but if the Democrats continue to control the Senate, that he will be able to rescind everything in the Affordable Care Act. I think one of the things that's complicated about Romney is, if you look at what he did when he was governor of Massachusetts, it's very, very similar to the Affordable Care Act. And some of the people who were his advisors in developing that program were also the advisors to the Obama administration in designing the Affordable Care Act. The other historical tidbit is, Eileen keeps talking about the bundled payments, and bundled payments is very much like health maintenance organizations that were created in the 70s. And health maintenance organizations were created and pushed by Richard Nixon. So I think the politics of all this is fascinating, and I think the answer is we just don't know. If Romney becomes president, he could turn into Governor Romney again.
President Governor Romney. Thanks, a great question, and one that we're all thinking about. So So from an academic policy person, Chris and I would stand up here and say to you, when we historically look at U.S. policy in health, it changes. It follows a sociological pattern. It changes every 35 to 40 years. You get a big change, and you don't get much in between those 35 and 40 years. And so the last one was Medicare in 1965, and this is the biggest change since then. So then the question, an academic would say, can it really be changed? You turn it around, get a new president, and all of a sudden it's going to change again. So once society really gets these levers in place to make a new change, policy academics would say, no, that's not going to happen. So it'll just, maybe they'll tweak it, maybe they'll try and do this. He might want a little bit more at the business level being developed in certain states. He has said he's not for the Medicaid expansion. Medicaid is the biggest question for this country around dollars and payment and taxes, because we have to still take care of those who need it the most, and at the same time, where does the dollars come to do that? And states need to use money for what? Education, health, and prisons. And so where do they get all the dollars they need? And so a governor is constantly trying to balance, where do my dollars go for health? Where do my dollars go for education? And where do my dollars go for prisons? And they're reluctant to take too much of it away from health, because that comes back to make them look bad more than the others. Education, of course, too. But health, it just has bad headlines to it when you have people who can't get care. So it's a long way to answer your question. My guess would be that not much will change, but some things will change around the Medicaid. The Medicaid wouldn't work. There would not. The incentives would be removed for those states that would want to join in right now to buy into the Obamacare or the Affordable Care Act Medicaid. If Romney comes in, he probably would remove those incentives. And so therefore, states wouldn't be participating in that Medicaid expansion, so fewer people would be able to get onto Medicaid. But that starts to unravel the payment of the whole Affordable Care Act, because it's that savings they're hoping to get that will cover some of the other cost of expanding the wellness coverage. So it's very complicated, and so we don't know. But that's where I think he would probably, and then put in some incentives for businesses. But the insurance businesses are already jumping in on this anyway. So they're already putting bundled payment plans, putting performance incentive, putting in the payment based on outcomes, putting in these teams, putting in efficiencies, helping nurse practitioners remove their barriers. They're already doing all of that in the private sector.
I don't know. I guess I would assume there's lots that he can do by executive order.
He could probably do the executive order by the Medicaid expansion. I'm not an attorney, but if you think about policy, the Supreme Court didn't uphold the Medicaid expansion, so there might be some executive orders around that could be done. President Clinton wanted to make an executive order to say that all nurse practitioners should be paid at this flat, or paid at the same rate as physician, or that have open scope of practice, but he couldn't do that because of states' rights. So as soon as you get into states' rights, the president can only do so much. But what can President Obama do as he's leaving office with executive orders starts to become the question, too. I bet he doesn't touch it and starts doing other things. But that's just my opinion, because that's what, as a policy person, we've seen in the past.
Thank you. Another question? Sir. Yes, third row.
Anecdotal evidence aside, have you done any public opinion surveys on how the public feels about nurse practitioners vis-a-vis general practice physicians? And is there a distinction between diagnosis and treatment?
Have you done it?
No, there have been a number of studies that have been done about satisfaction with care, which is not exactly the same thing as how people feel. But when you look at the evidence about satisfaction of care for patients who have seen nurse practitioners and patients who've seen physicians, there's essentially no difference, or they're more satisfied with the nurse practitioners.
That's post-treatment. Is there any attitudinal pre-treatment distinctions?
That I don't know. I don't know of any, but that doesn't mean that there aren't any. Do you know of any?
I'm not aware of any direct survey that looks at would you see a nurse practitioner that's large enough to draw conclusions from. Certainly, students and have done some small studies to say, go out and survey 50 people and see what that is, and people say they would be open to it. The largest study was done in 1986, looking at satisfaction with physician assistants, nurse midwives, nurse practitioners, and had high rates of satisfaction, and it also showed high rates of care that was better documented, which I think is particularly important in the telehealth world today. I did a study which looked at comparing the nurse practitioners and family physician data on whether they considered the work different by the coding of CPT codes, and there was no significant difference between nurse practitioners and family physicians as to how they valued the work, in other words, for payment system, and that work was used to then justify the inclusion of nurse practitioners in Medicare payment and Medicare physicians. But the markets speak for themselves. Certainly giving people choice is always a good way to go when you come into a health system. Would you like to see a nurse practitioner? Would you like to see a doctor? Would you like to see a woman doctor? Would you like to see a man doctor? How would you like to see that? It's a good system for choice. And if you're going in the way that I think you're going, when we look at that within systems, so in the system that I worked in Pennsylvania, people will choose nurse practitioners if they're more available, if they've never had one before, but you can see the nurse practitioner today, but next 3 days from now is when the doctor's available. And then once they have that service, they want to come back. And so it is that initiation of exposure to what the nurse practitioner can provide, as this woman was sharing in her experience. The other thing that we do know from, I guess it was Marla Salmon and Fitzhugh Mullins' states study years ago that was in the New England Journal, that the states that had better laws in the 1980 for nurse practitioner physician-assisted practice had more availability of nurse practitioners per consumer because they were more there. And the people in that state had higher recognition of nurse practitioners because they were able to flourish in a state that allowed for the laws to do that. So that's pretty much the background.
But my second question about, do people draw a distinction between diagnosis and treatment? Is there an attitudinal force out there that says, well, they can provide the same treatment, but doctors do better diagnosis, or they're better trained to do diagnosis? Does that attitude prevail anywhere?
Not that I'm aware of, except coming from organized medicine. So it's very clear that you can look on the organized medicine websites. The American Association of Family Physicians came out with a statement just in the past few months saying that nurse practitioners are not able to lead teams, and that there's no evidence to support that statement whatsoever, because they have been leading teams in nurse managed centers. We've all been successfully practicing for a long time. There's fewer lawsuits. There's no evidence that nurse practitioners have had any problems with licensing any more than anyone else has. So that there's nothing to fly in the face of that. The Peter Bjorhaus and some other colleagues are trying to look at some Medicare data around whether nurse practitioners order more tests or few tests or diagnostic, and they reported some preliminary data last week at the American Academy of Nursing and found really no differences whatsoever. And so I think if you're a primary care provider, you're a primary care provider, whether you're a physician assistant, a nurse practitioner, or a physician. And then within that, what are the nuances? What are the differences around those groups? From a nurse practitioner perspective, you're going to get a much more holistic provider who's looking at your full life, and because we prepare nurses to really think about people functioning within the context of their lives. And so you're really, think about what's going to happen with this person when they leave the door. What's going to happen when they're walking in the door? For example, as an anecdote, when I had practice in New Hampshire, I remember distinctly seeing a gentleman who had pulled a car up to the front of the building where we had our office, and watching him walk up the driveway after he got out of his car and then coming into it. And I said, he came for something else, and I said, the man has vascular disease, the way he walked up that driveway. And brought him in, and indeed he had long-standing vascular disease, and it was danger of losing his legs. And without watching him walk up that driveway, because I stick my nose into other people's business because I'm a nurse, you might not have noticed that whatsoever. And, he was an independent, proud man, and he didn't necessarily want to bother us with that, but we got him taken care of. So I think it's those kinds of ways that we think of the holistic. And I don't want to get on my soapbox, but society gives nurses the ability to step into areas of their lives, and that's why you trust us more than anyone else. And so when you couple that nursing with nurse practitioners, you get a different kind of provider. But it might mean that I, as a person, might one day say, well, I'm happy to see the doctor this day if he's there and the nurse practitioner is too busy to see me.
Thank you. One final question, and we shall take it from Sabina in the third row.
I have a quick one, and then, so first of all, I know you're talking about nurse practitioners, but for just RNs who are not that, where do you see the growth in the next 10 years? Is it obvious it's also going to follow into the community in these clinics and not so much in hospitals?
I think what's going to happen is there's going to be big changes in how we deliver ambulatory care, whether that ambulatory care is for chronic conditions or for acute episodes. And I expect that there will be lots more expanded roles for nurses in ambulatory care. And I think that's going to happen when the insurance companies or physician groups or nurse groups do this bundled care. They're going to say, well, we have to provide A, B, and C, and who can do what. And there's a lot of registered nurses who are working in ambulatory care who are not working near the level of what their education would enable them to do and what their skills are. So that's where I see a lot of growth and change. And in the other areas, I think that much of hospital care is getting much more complicated. And I see that registered nurses are going to have expanded roles in areas like the ICU, where they're just going to be allowed to do more things than they're allowed to do now. And I don't know how I think it's hard to figure out how that's going to play out, because the rules of what people can do differ from state to state, and the rules of what people can do differ from organization to organization. How nurses function in the various hospitals in New York City varies because of what's going on in those hospitals and the decisions they have made.
And another way to think about this is that if we're here in 5 or 10 years, I don't think we're going to be talking about settings as much as we're going to be talking about how we manage data and technology. So yes, there will be places, there will be hospitals, there will be intensive care units, and then there will be everywhere else where data will be delivered to so we are hearing more and more about the resurgence of nursing in workplaces. So, employers want to, with an individual mandate, they want to keep people healthy that they're paying the insurance for. And so nurses and others will be back into the work setting. But the majority of people are still majority of nurses are still going to be in hospitals. Chris and I
the majority will be
that.
There,
They're still going to be there.
Just an anecdote. My daughter works for the New York Federal Reserve. She's an economist. And those are, many of the people who work there feel an incredible sense of entitlement and have access to income that is different from what nurses have. And the New York Federal Reserve has a health clinic, and it is staffed by nurse practitioners only, and the staff use it a lot. And they use it for, I have a sore throat, or I have a headache, but they actually get care. And according to my daughter, everybody's very happy with the care they get, and they do it. And I think the Federal Reserve probably figured out that it's a lot better to provide the care than people taking off a half a day or a day from work to get an appointment with their usual source of care.
Yeah. And they certainly had a lot of headaches.
Right. They had a lot of headaches. They still have a lot of headaches.
Can I just follow up on the one other thing that you said before? When you said that Medicaid might be cut, or it's not going to happen in some states, older people, I mean, this is the boom for demand, right, the geriatrics. So if you're 65 and older, you're covered by Medicare. So I'm wondering, who is it, the new 40 million who are going to get hopefully care through the ACA. If they don't get, they're under 65. If they are not getting Medicaid to go to the clinic, then where are they going to go? They're going to keep going to the emergency room, or they won't get care, or they'll escalate and go to the emergency room and it'll cost more.
Right. So part of the individual mandate is for people who are eligible for Medicaid, so that you raise the eligibility for Medicaid, you're expanding the individual mandate. And so that's why these incentives are there for states to agree to this Medicaid expansion. So your question, no one knows the answer, but you're absolutely right. Now you have to understand that most Medicaid dollars are still spent on older adults, and they're mostly older adults who are in nursing homes. So what really
that was exactly the thought that was going through my mind. I was just going to say, it's amazing.
Yeah,
they need that to in addition to the Medicare?
Yeah, because Medicare doesn't cover nursing home care. Only Medicaid covers nursing home care. And so Medicare will cover, rehabilitation after hospitalization for 30 to 90 days, depending, and it will cover some skilled nurse visits in home care. But that's only for a very brief period of time. And once you're just in need of long-term care because you have dementia, because you have physical, you either pay for it yourself out of pocket if you don't have long-term care insurance, or you spend all your dollars and then you're eligible for Medicaid. So the middle class income spends down and then goes on Medicaid and lives in nursing homes. And Medicare doesn't cover that. Only Medicaid covers that.
Well, thank you all. At this time, I would like to thank our two scholars. And we certainly thank you all for your attendance and participation. So certainly today, on behalf of Dean Sullivan-Marx, Dr. Christine Kovner, the administration of the NYU College of Nursing, we thank you for your participation today in NYU Alumni Weekend. Have a wonderful evening. Take care. Thank you all.